So, what about these teeth? We have a pocket, we have a defect around the central that involves also the lateral, even if we don't know anything about the lateral, because the central is affected for sure, because there is also the mesial defect and the bone peak of the homologous central is perfectly healthy, while the root between the central and the lateral are so close that it's obvious that there is bone loss of both. No doubt. So this is very important for you to know. And now the question is, can you regenerate from a periodontal point of view this defect? And if I look at the radiograph, I can tell you, oh my God, I regenerated much, much more severe defect than this, even if there is a very, very important tooth mobility. But the defect, it's all around this. And it's, from a bone point of view, something that we can really make a lot in terms of periodontal regeneration, in terms of hard tissue defect. But now we have to go to the soft tissue. And when you see that between the two roots that is sharing the defect, there is no soft tissue to cover them, to give stability to the blood clot that is forming in the infrabony component of the defect, you know that this defect cannot be regenerated at all. I have the picture of this patient because this patient came to me and I told the patient the central incisor has to be extracted immediately. And then he went to another guy who said, don't say this has to be extracted because I'm looking for a miracle. And so he did scaling, a root planing, and 3 months later, the patient came back to me because the recession was 3 times bigger at the level of the papilla, you know. So you have to be careful before deciding to do something that is completely difficult to restore after. And you see that during the healing, during this 6 months of healing, we maintain the pontic of the Maryland short, not too short, not only for aesthetic reason, but in order to leave the soft tissue to progressively fill the space between the soft tissue and the pontic itself, and then use this very, very small burst in order to reduce the pontic progressively and leave some more space for the soft tissue to heal before getting in contact again, because it's completely wrong to remove the Maryland that has to be fixed very, very well, since it should last for many, many months without giving any problem to the patient. And when, with respect to the last modification you did on the pontic, there is no further growth of the soft tissue that is not getting in touch anymore with the reduced pontic, despite it was reduced about 2 months before, this is the time in which you can take decision. And this is never less than 6 months after tooth extraction, because the soft tissue has a good tendency to heal if you don't disturb the healing of this soft tissue with the pontic. Obviously, if you create a pontic that is compressive into the tissue or into the socket at the beginning, this is crazy, because it's exactly the opposite. What you want to do is not to create a false pontic into the socket, but to allow the soft tissue heal in order to minimize the amount of soft tissue segmentation you need when you are going to treat the dental site. So now we know that our reference is still the same, and this is the distal papilla of the homologous natural tooth. And we know that this is not as bad as it was at the beginning. Now we have about 3.5 millimeters of papilla loss, and not 5 anymore as it was when there was still the central incisor. So this means that we have less amount of soft tissue segmentation we need at the level of the mesial aspect of the central with respect to the condition where there was still the tooth. So it's not true that if you allow the soft tissue the time to heal, time means not 6 days, not 6 weeks, but 7, 8, 6 months at least, you can gain soft tissue height, and it's not true that you always lose soft tissue height. And obviously, if you look at the occlusal aspect, there is a loss. There is a lot of buccal lingual soft tissue loss together with the apicocoronal soft tissue loss. That means papilla loss at the level of the lateral. What is the technique that we use to augment the soft tissue in the edentulous site? This is a technique that is called connective tissue platform technique. Is a technique that was introduced many years ago for the pontic area, so not before implant placement, but now has been obviously applied as a soft tissue augmentation technique before implant placement in the case of tooth extraction for periodontal disease. And we have to create a buccal flap that is so free to advance coronally and reach a palatal flap. Both flap, buccal and palatal flap, has to be elevated split thickness in order to leave as much as possible intact the soft tissue that is comprised between the buccal and the palatal flap that we call platform. The buccal flap elevated split thickness has to be advanced coronally so to be able to overcome the platform and reach the palatal flap and make everything heals by first intention. After, many connective tissue grafts can be applied at the buccal aspect of the platform and the occlusal aspect of the platform to increase simultaneously the buccal lingual and the apicocoronal dimension of the soft tissue height of the dental site. So now we have to decide which kind of coronally advanced flap we can make at the buccal aspect to allow the buccal flap reach the palatal flap, since there is no way to advance coronally the palatal flap. And we know from mucogingival surgery that there is two way to advance a flap coronally. One way is the trapezoidal flap elevation with vertical release incision, and the second way is the envelope type of flap. And obviously the first choice theoretically is always the envelope type, because it's easier without vertical release incision. It includes also the possibility to improve the adjacent teeth, but the amount of palatal displacement you can make with your coronally advanced flap with the envelope type of flap is nothing compared to the amount of palatal displacement you can make with the vertical release incision. So when there is a lot of palatal shift that the buccal flap has to make, we need vertical release incision. So the platform, which comes from the split thickness elevation of the buccal and the split thickness elevation of the palatal flap, in order to create a greater connective tissue base of this platform at the level of the bone and a minor connective tissue base at the level of the occlusal aspect, is now to be transformed in a connective tissue platform by desepithelializing, removing the epithelium that is comprised between the buccal and the palatal incision. So now I really have a connective tissue platform from where the name of the surgical technique comes from. And now I have to decide, since connective tissue graft will be applied both buccally to increase the buccal lingual dimension of the soft tissue at the level of the dental site and apicocoronal to increase papilla height, where do we apply the connective tissue graft first? When the platform is 3 millimeters or less, the connective tissue graft has to be applied buccally first. Why? Because by applying the connective tissue graft buccally first, I can increase the buccal lingual dimension from 3 to 5. And so it's easier for me to apply the connective tissue graft occlusally, that instead of being 3 millimeters wide is 5 millimeters wide, and this gives me more possibility to improve papilla height. So occlusally first, and then buccally first and then occlusally in order to increase the apical colon and the buccal lingual dimension. And if you look carefully, compared to the mesial papilla, you also have to consider that this graft will be completely covered by the coronally advanced flap, because this graft will never survive if they're not fully covered by the coronally advanced flap. And I have to tell you that 90% of the survival of this graft don't comes from the platform, but comes from the covering flap. And so it's absolutely mandatory that your buccal flap close by first intention completely to the palatal flap. So make the platform like this, very thick graft at the buccal aspect, thick graft at the occlusal aspect, and then close everything. Yes, close everything means close everything in the palatal aspect, but please take a look of the buccal aspect. Is this the same picture you have when you make bone augmentation? When you make bone augmentation, the lip of your patient is perpendicular, yes, to the occlusal aspect. While here you can see how nicely the soft tissue with alveolar mucosa perfectly covers the volume of the connective tissue graft, but it's perfectly vertical. So the vestibulum is completely restored from the time of the surgery, or even increased with respect to the starting point. And why? Because I learned how to treat gingival recession in the lower incisors. Remember? Verticalization of the flap. Remove the whole submucosal tissue, the muscles from the periosteum. Anchor the vertical release incision with the periosteal bed. Yes? So this is concept that really comes from the treatment of those areas that have no depth of the vestibulum for anatomical reason. In this case, the restoration of vestibulum depth is mandatory because we need to treat the defect. And so even if there is a frenulum, this has to be completely inactivate by removing the whole muscles and the whole submucosal tissue from inside. And this is a flap that compare in its apical conal dimensions, perfectly attached. Yes? Same out. The only thing that is increasing is the volume because of the underlying connective tissue graft.